post-banquet 8 a.m. session. So we have slides. We were hoping Dr. Nazrul Islam would come. We could start with the keynote, but anyway. So this course is navigating the thorns in the MIGS path when all is not well. And since MIGS is now having a mixed response, even in this conference as time has gone by and people have understood the limitations, we thought it's important to understand what we really go through. Why is it important? Because MIGS is not all roses. It's a new kid on the block, yes, but not without its share of challenges. There are technical challenges, a learning curve, intraop gonioscopy, we have a confined space to operate, and the understanding special devices and instruments. So you also need to importantly understand suitability of the patient, and managing intraop and post-op complications is important. So the outline of the course is going into before we rush in, what not to do. And then when you finally take the plunge, the stumbling blocks, once you're in, ensure all is well. And now that the deed is done, what may go wrong? And then we'll have a panel discussion with case scenarios. I'm privileged to have on course with me Professor Pandav, the head of the Advanced Eye Center, and Dr. Srishti Raj, who's professor in the glaucoma services, and Dr. Faisal, who is also additional professor in the glaucoma services here. And we hope to have some audience interaction if so. So we can continue from there, or we'd like to come here. Either. So Professor Padda would be doing the first, and I think since we are the audience, we can keep sitting there.
Thank you, Dr. Sushmita, and thank you for including me into this program. MIGS, before you rush in, what not to do. The first thing you have to do, not to do, is don't rush in. You don't have to rush in. So if your indication is that other people are doing MIG and I must do it also, so that should not be the indication, because there are alternatives, and you have SLT medicines, traps, tubes, and we have been doing them and managing these patients with these methods for so long, and they are still valid. However, some patients are likely to benefit from MIGS. So important thing is to identify those patients, and those are the reasons where you could consider doing MIGS, learn these MIGS and offer them to your patients. Second thing is that MIGS are not for every patient. For advanced glaucoma, they are not recommended. Avoid MIGS in advanced glaucoma cases where the visual field, there is a severe visual field loss, because MIGS are unlikely to meet target IOP in those conditions where the requirements are low. MIGS are indicated basically for mild to moderate disease or ocular hypertension where you want to treat. Another thing you have to keep in mind is the risk of bleeding. So if your patient is the one where the risk of bleeding is higher, you have to be careful in doing MIGS. Patient anticoagulation therapy long term, or other hematological disorders where you have higher risk of bleeding, you have to avoid MIGS or control it nicely before doing MIGS. And also if you have a vascularization anterior segment iris or angle, you can't do MIGS in those cases because there will be a bleeding, which is the commonest complication with the MIGS anyway. Avoid MIGS when there's an extensive peripheral anterior synecdoche, and also especially if there's an inflammatory conditions of the eye, if you have a uveitis, chronic uveitis, and there's a lot of synecdoche already. I think those are not the cases of the MIGS, because even if you do a successful MIG, it might actually close later because of the ongoing synechial inflammation, which will lead to more synecdoche formation. Important thing is, if you're not familiar with the procedure, I think you have to be familiar before you do MIGS. So you need a microscope which can be tilted. You need to turn the patient's head to the opposite side. And since you are operating on the temporal side, sitting on the temporal side, so the position of the microscope, your surgeon's position may be a little awkward for you in the beginning. So it's very important to get familiar with the operating room setup, the procedure, and before you actually start doing any MIGS surgery. Proficiency in intraoperative gonioscopy very important. It's like you don't dive into the pool unless you know swimming, and gonioscopy is something like that because that's very very basic. Unless you are expert in swimming or good in swimming in gonioscopy, you can't really do MIGS. So you have to learn gonioscopy in the clinics and also direct gonioscope in the operating room before you can do MIGS. Then if the angle view is poor for any reason, you should not be attempting MIGS. And then important thing is train yourself. So attend some workshops, wet labs, observe other people doing it, and do under guidance a few procedures before you can start doing them independently. Another important thing is the patient understanding and cooperation is very important. So if you have a patient which doesn't understand what you're doing, that's true for all glaucoma surgeries, but especially true for a MIGS because some of them are very expensive and the desired outcome may not be to patient satisfaction. So you have to explain them to very carefully. And if you're doing it topical, then the patient cooperation would be needed. So it's better to start with with some anesthesia, maybe perivalvular or retrovalvular or some other. But you can potentially do them under topical anesthesia, but then the patient has to understand what is being done. And most importantly and lastly, the patient's safety is very important, and you have to consider the procedure in relation to the patient's clinical characteristics. And this was the patient we did GAT, and you can see there's a bit of hyphema there. And it doesn't look much, but the patient came with a pressure of 55 millimeters of mercury the next day. And if you have a disc which is already damaged, that much pressure could actually compromise the visual field and visual performance later on. So hyphema is the commonest complication. Most of the time it's not of much consequence, but once in a while you can get very high pressures, and that could be detrimental to the patient's vision. So thank you very much. That's all in 5 minutes. Thank you.
Thank you, sir. If you could just continue on the dais as we carry on the course. So I'll continue. If there are any questions, since we're hardly anybody, we can stop and take us, but we can take it off otherwise also. So, yeah, can we have the slides, please? So now that we've gone through who not to do and how to start, when you do finally decide to take the plunge, there are some stumbling blocks, and we'll go through that. So like Dr. Pandav just said, training, that's the first and the most important thing. Unfortunately, I don't think there are any structured training modules anywhere where you can go and really train for MIGS. But it's nice in this day and age to read and watch videos, and if possible, assist. That's the best thing that can come, because you can see even assisting a MIGS requires a lot of torticollis because the microscope is tilted. So the poor assistants are usually tilted on one side. We don't realize that when we are doing surgery, because the eyepiece of the microscope cannot be tilted to the assistant. And most important is invest in a hands-on dry lab or a wet lab. Nothing works more than getting a feel of the procedure. And we did conduct a very successful MIGS workshop a couple of years ago, and we were surprised at we expected it to be a workshop for comprehensive ophthalmologists in and around Chandigarh, but people from across the country flew in and came and did that. So we realized that we maybe do this more often now. But investing in a workshop where we had Dr. Leonau come in from Manchester was really, really good. And this was like really early days of MIGS when we were also not so confident of doing it ourselves. The second thing, of course, is get the right equipment. There is no point in shortchanging yourself if you've decided to do something. A direct gonio lens, a good direct gonio lens like a Swan Jacob is our favorite, but then disposable lenses could work, except that with repeated autoclaving and ETO, they tend to become very hazy. This particular Swan Jacob, which is in the autoclave box, has been there since 2017. It's used multiply by all consultants, all senior residents, some junior residents as well. And believe me, even today I can pick it up and I can do a MIGS and there's no problem with it. So that initial cost is offset very, very well, and I always say that. Understand the funda. So as Sir said, the funda is to tilt the microscope, of course, so that the idea is that if you have the angle like this, you're not going to be able to see much. You have to tilt the patient's head so that the light from the angle goes up and falls into your eye as the surgeon. So that's the idea of tilting the head of the microscope optimally. There are some surgeons who say that you can put a mark on the microscope, but remember, every patient's head, every patient's socket, every patient's eye is different. So it's not that having a mark is going to hit the spot every time. It's around 45 degrees, but okay, it's fair to have a mark, but remember that mark may need to be adjusted with the tilt of the head and what else you need to do. So this is, it's being demonstrated on a baby because goniotomy was where we started, and that's the mother of all the MIGS really. So you do need a coupling agent on the cornea, and that's how the Swan-Jacob lens gently rests on the corneal surface before you go in and you get a good look at the angle. The next stumbling block is angle visualization, and some of the people who we've spoken to who talk to us say that that's easily the most difficult thing, because usually when the person has embarked on a MIGS journey, they're already proficient intraocular surgeons. So the intraocular maneuverability is not as difficult as visualizing the angle. Again, dry eye model is good. Madhu eyes are good to see that. You get a feel of holding a gonio lens, and I'm just going to take you through snapshots of our residents at the end of the OR or between cases. I tend to give them a dry lab, and the tilt is by this cotton which is there, and the dry eye or the model is on it, and they are given a chance to hold the gonio lens. And believe me, for the first time when they assist in lots and lots of cases, they say that it's crazy, we just can't figure out how to do it. So this is really a second year JR. She's trying her best, but she's going up and down, to and fro, and this is what is going to happen to you on a live patient as well. So then it's a bit of a struggle, and this is Vaishak. He's holding fort while all of us are here. So he's come in and he's watched her struggle, and then you need a little bit of that nudge, and he says, "Arey, it's not tilted enough." So he tilts it for her. So it's important to have somebody who is along with you, but otherwise it's usually trial and error. And voila, I think she'll be able to see the angle now. So this is actually just a model eye which is tilted on an iPad in the OR to start with. The next is to train to see on fast. Now you've got the microscope in, you've got the lens in, and now there's nothing that you see. So the training is to see an on fast view of the trabecular meshwork, which means it has to be absolutely perpendicular to what surgery you're doing. And if it's a little tilted, then you're not going to be able to operate on the angle as much as you should. So this, like I'm standing on her head, but I'm telling her it's not enough. She thinks that she's taken a good view of the angle, but this is not a good view of the angle. If you have a bump of the iris which is going into the angle, when you're going to engage the angle or you're going to try and put in your instrument into it, this is going to keep coming up. So the head has to be tilted a little more. So this is what I've told her, that no, this is not good enough. Go a little more, go a little further, and you see the difference between this angle and this angle. So you might be tempted to go in and operate here thinking you've seen the angle, but the angle that you see has to be like this. You have to have visualization of the scleral spur and the trabecular meshwork, which is on fast, and the only thing that she's done is tilted that model eye a little more, but actually tilted the head a little more. So, or you tilt the microscope a little more, but this is the sort of view that you need. Now comes the real thing. You need the intraoperative dexterity for surgery of the angle. So you're holding your gonio lens. That's why the visualization is so important. Before you go in, there's no way that you can manipulate the eye once your instrument is in. So now that she has an on-fast view, I've told her now you go in, and this is the view from the microscope. So she's put in the the Swan Jacob lens, and this, I think this angle has been operated upon by somebody else as well. So then the dexterity of going in, I've just let her start with an MVR blade to just go and niggle the angle and get a feel of what an angle surgery would. A good starting point would be to go in with a blunt Sinski hook and do this and get a feel of manipulating the angle in every cataract surgery that you do and get the feel of it. And it's nice to do it before the lens is taken out or before the surgery is done, so that inadvertently you do your first few lens touches in a patient who you've planned cataract surgery, so it won't be so catastrophic. So this is my second year JR who has actually done a wonderful goniotomy on this model eye. And when you actually say go for it, it's really something. So once in, now this is a senior resident who's actually doing a bang once I've done the goniosinuculitis. But the bane of MIGS surgery is the air. So this happens to all of us, and he's asked the sister to inject because he wanted the iris to go down a little bit, and there you are. So this happens, and you say you've done all of that, you visualize the angle, you're ready to go in, but you put in a bit of viscoelastic, and there you are, you have this big bubble of air. So these are a little bit of the stumbling blocks when you start off, but that's okay once you get the hang of it. Best of luck, and we hope everybody joins the MIGS bandwagon. Thank you. So I'll now, I think, invite Dr. Faisal, please, who will tell us once you're in, and then what do we do? We can take questions along the way, or we can take questions at the end. Please feel free to ask anytime. Sorry, so the instructions are the mic so that the question is also recorded.
Yeah. So, madam, I do in the Angenuity Vision System. I tried in this way, but it was a lot of like neck pain and all. I struggled a lot. So we have the Angenuity Vision System. I tried in Angenuity Vision System. It's very helpful actually. So pleasing. There is no stress at all. Now, thing is that one thing is that there is a lot of bleeding actually. Bleeding happens, and most of my cases I have not tried in like phakic cases. I tried in like which I contemplate cataract surgery. Before cataract I do. Now like regarding the hemorrhage, what like how to deal with it, or what is the like that is my question actually. This how problematic it is.
So we have a slightly different approach. We think that when we operate on the ingenuity, we all get neck pain because it's not straight. We have to operate like this. So we've stopped operating, and on the microscope, actually, we're just more used to it. But if you really sit up and you have that straight, you shouldn't be having any neck pain. That's one. So
Okay.
maybe the tilting of the eyepiece is not optimal. So that eyepiece, if it's absolutely straight and you're looking straight, then there is actually no problem. One tip is to get the patient close to you. Otherwise, when the patient is in the middle of the table and you tend to do
Yes,
that,
yes,
that
yes.
is when you tend to, bend
Yeah,
forward a bit. But have the patient a little to the edge of the table as far. Use a head ring. Don't put the patient on the table. So then you can go in up till the patient's head. So even with phacos, if I don't use a head ring, it doesn't matter. But otherwise, with the MIGS, I always use the head ring so that I can go straight in and I don't have that table obstructing. So if the
Okay.
patient's head is here and I'm here, there is no neck pain at all. It's absolutely, that's one tip of the neck pain, because most people will not have a crore plus for the ingenuity machine. So just tips for that. Bleeding, I always tell my residents and fellows that bleeding is a scleral problem. It's the fact that there is bleeding when you're incising
Yeah.
is that if you feel tissue, you're too deep. That's what I've learned. You should visualize tissue. So your first goniotomy and everything and bang has to be a visual thing. It has to be like a hot knife through butter, feeling nothing. The minute you're feeling that you're cutting tissue,
Yes.
you're actually scratching sclera.
Okay.
And that's where you're going to bleed first. And if you've bled on your first goniotomy, that itself has, it sort of rogers the rest of the surgery. So try that. Try not to feel tissue.
Okay.
Try doing that initially. Don't feel it. Just see it. And if it's scratchy, then it'll bleed. But having said that, GATs, even if your initial goniotomy is okay, somehow when you go around, they do tend to bleed. There are some surgeons who say that it's good that it bleeds. I don't like the bleed at all. I've picked up a small tip from friends I've observed all over that when they finish with the GAT, so you have an AC maintainer ready,
Okay.
right? And it's full of visco at that time and put in the AC maintainer so there's no bleed. Then switch it on. Slowly that visco will get washed out, hydrate the first port. And then be ready with your visco. Take out the AC maintainer, put a little bit, it's called a donut, little bit in the angle and then just hydrate.
Okay.
So that has helped. The second tip for GAT and all others is have a little bit of 10 degrees tilt of the table, up a reverse Trendelenburg. Usually if the head is above the jugular, then that seepage is not there. So you have to be a little higher than the heart. Small tips, but you'll get there.
Okay. Thank you. Thank you.
Thank you. Good morning, and thank you for including me. So first, I thanks my mentors and my student. Without their support, I can't stand even here. So MIGS, the term was coined by Dr. Ike in way back in few decades back, and it was recommended only for mild to moderate glaucoma, not to replace your conventional surgeries. So as we know, MIGS is it's a device which lower the intraocular pressure with minimal manipulation of the ocular tissue. So it has high safety profile, minimal disruption of the normal anatomy, preferably abdominal approach, and efficacy should be at least 20% IOP reduction or reduce the number of medication at least one medications. So now we have prepared the patients, now you prepare the eyes, and now how you go and come out safely. The first and foremost, if you are in the beginning, you after tilting the patient, before entering to the eye, just do a gonioscopy and confirm the adequate tilting of the microscope over the patient eye. And if you are not, recently I started doing putting the trifine blue dye, which will nicely delineate this non-pigmented trabecular meshwork. It's very helpful for beginners also. So prepare the needle for, especially for the bangs. We started with 24 gauge needle. Now we are using 25 gauge needle. So 90-degree bend with reverse cystotome form. So the first and most, how to make a side port. The first side port, this should be purely a clear corneal incision. If you injure the limbal vessel, it will going to bleed, and the blood will come on the surface of the cornea, and between the lens, it will start the mesh. The beginning itself will be meshy. So avoid limbal vessel injury, and the size should be adequate. If the size won't be adequate, you can't get it to and fro movement of the needle within the eye. So if you in the second photograph, when I trying to move the needle, the eye also tilting. So that means your side port was not adequate in size. So now fill the viscoelastic. Put cohesive viscoelastic, not the dispersive viscoelastic, and place the lens and focus the angle structures. So now once you are focused, entry parallel to the iris, don't hit the corneal endothelium or the anterior lens surface. The first video is the bang, and other one is the KDB. The pearly white structure, now you can see, that is the posterior wall or the outer wall of your Schlemm's canal. That should be aimed, that should be visible. Don't feel the tissue, and just incise into on as much as you possible. 90 to 120 degree you can easily done. So this is the I used a dye. So this now the anterior trabecular meshwork is more visible just inside through that line. So if you don't see what happened in last one of my cases, the structure was seen as very blurry. What happens really that I was not placed my lens properly over the corneal surface. Yeah, now in between the procedure, the structure become blurry and there is a gap between the lens and the cornea. So that happens, so your left hand should be very steady and exactly follow the contour of the corneal surface. So don't feel, the madam already described the structure, don't feel the structure. So in the first video, the surgeon tend to uh, go posteriorly and hit hit very deeply, then start the bleeding. It's the first hit itself. So that means you are entered in a wrong plane. So that lead to more bleeding. If the bleeding happen, it will come on tendency to come up more again, and the procedure will be more complicated. So avoid bleeding the first itself. And in the second video, what happened is the first part of was good, going nicely. Then, yeah, now I tracing the supranasal angle. What happened is I hit the posterior surface of the inner part of the Schlemm's canal. Now the bleeding point has started. Yeah, you could see the bleeding point here. That means if you hit the posterior surface, you will drag the eye or you rotate the eyes. If that means you are hitting more on the posterior or the outer wall of the Schlemm's canal, that point you will get a bleeding point. So don't hit, just don't feel any structure, you just inside the anterior trabecular meshwork, so the posterior trabecular meshwork will push down. So this is the two procedures that taken from the ma'am and sir the video. The iStent is little bit more easy. The instrument should be, don't touch anywhere in the cornea or endothelium or the posterior surface of the lens, and just inject the implant in the trabecular meshwork. For GAD, there's little more learning curve. After putting the pilocarpine and putting we are using 50 Dacron for more, that is more cheaper option. 550 Prolene, sorry. Yeah, now you make just a small incision. You could see the white pearly structure, that is the Schlemm's outer wall of the Schlemm's canal. Now with your max grip, just now just very smoothly, very gently insert this suture material very smoothly. Don't get, if you is not going, don't keep pushing. It should be gentle movement. Yeah, once it come out, just remove, just pull out and take it out. So to summarize, the gonioscopy visualization for angles are very important, and entry incision should be at clear cornea and with adequate sizes. Can use a Tiffany blue at least in the earlier stage of your training, and entry with needle knife or knife before placing the lens, because initially if you put the lens initially, then if you're trying to entry it will be difficult. So entry into the SE, then put the lens, then go ahead with the help of lens. And steady the lens over the cornea, go parallel to the iris, away from the endothelium and the lens capsule, high the magnifications, and focus on the non-pigmented trabecular meshwork and inside it, and pearly white appearance in the posterior wall of the Schlemm's canal, and don't feel the tissue, and if don't see the structure, stop there itself. And take care of the endothelium and the lens, and inject the air bubble at the end of your procedure. And you can turn the patient on the ipsilateral side. If you are doing the right side of the patient, then ask the patient to maintain a right side position so that air will go to the nasal part of the where you did the procedure. Thank you.
Thank you. Thank you, Faisal. Please join us on the desk. Any questions? So I think one of the most important thing he said was that if you're feeling your eye move, that itself tells you that you've engaged the sclera. So when you're moving this, your eye shouldn't move. Your eye should be there and steady. So that's a very important tip. Thank you.
The thing is that injecting the dye is a good idea to, you can see
Yes.
that getting peeled off, but doesn't interfere with the overall visibility through the eye.
Procedure, if you, then I usually do, but it won't interfere the other structure, because this was learned from last GSA itself, Dr. Venkatesh, and they're doing it for every cases. But if you are not doing a combined case, it may be stay in the lens capsule also. So at that scenario, I won't use dye. If it's a combined procedure, definitely now I am using all cases with dye actually.
Yeah, and the important point is if you target the non-pigmented meshwork, then usually it's all right. If you target the pigmented meshwork when you start with, that's when you're likely, especially when you're doing GAT. I've noticed that the incision has to be in the it has to be higher rather than start in the pigmented. Then you tend to go down into the ciliary. And the other tip with GAT is have the instrument pointing up rather than down. So if it's pointing up, then it is likely to be in the trabecular meshwork. Otherwise, there's a tendency to it to dip in. So your suture shouldn't be dipping down in. So that's it.
And
Any other?
same is true for the eye stent also, because you don't aim at the pigmented trabecular meshwork, aim at the upper part.
While doing that, I have observed that the other end of the suture, which needs to come out, doesn't come out itself. Little like, I have not been able to bring hole and bring out. You get the point? So, you get the point? What I mean to say, the one it has gone 360 degree, but the point which should come out, that is the original that one with a bulb. No, it's not coming out. It's sleeping behind the angle. What is the problem behind it? Why is it so?
No, how do you know it is 360 if it hasn't come out?
Yeah, I can see from the no, this is the system. No, I can see that is going. The trading is going on.
Okay.
I can nicely see the other one coming out.
Okay.
But still, then it has not come out in the AC. What is this? Why is it so?
It has not come out. It should.
Is,
If you've seen the other end coming,
yeah.
I mean, either it has gone in again. So that
Yeah,
you
yeah.
just
That's
have
a,
to-
my question is that
Something does go in again.
yeah,
goes
again,
in
yes.
again.
My
And
question
then
is that
when
why
you-
it should go? It should come out.
No,
What is the
no.
reason behind it?
No,
There's
you
enough
should
space in the
you
canal.
should be hawk-eyed at your incision, and the minute you see the bulb, you should hold it before it goes.
Okay,
So
okay,
keep
okay.
looking. So usually in an adult eye, about 20 throws you can see that. So if you've made about your 15 to 20 throws, then you have to be very careful and see that it's coming out. We are always focused on that because everybody else says aage, aage, aage. So then we just pull it out.
Okay,
But if it goes in, then again you can go from inside and just pull it out. There's no
Okay,
problem.
okay.
More commonly I have encountered is that it tends to get stuck somewhere.
Yes.
So that's the problem with not having the eye track, because with the eye track you can do a cut down and then pull out how much ever has gone. But I've noticed that even if it's not coming and it's getting stuck and I've pushed and it's not coming, then it is possible to just pull it out gently and it does garrote out. It doesn't come out of the canal like that. If you pull it gently with the other, the trabecular meshwork does get sheared. And it's okay if you've done 270 degrees or 250 degrees, it's fine.
Okay.
It's something is done, it's not.
Okay.
And you can do then a goniotomy of the rest of the angle, so we sort of do that. Right, now Professor Srishti Raj is also with us, and he'll talk of now that we've done, now what may go wrong. Now let's see.
Thanks, Dr. Sushmita, being a part of this IC. So, there is no financial interest involved. So, what can go wrong after the MIGS has been done? We know that MIGS has a high safety profile and it's a safe surgery compared to the trap or other stents like ADI or AGV. But complications do occur, though most of the complications are mild and may resolve of its own. So, the different MIGS done are trabeculotomy, goniotomy, GAT, bank, KDB, trabectum, all these are done here also, except the lower one, which are definitely cost effective, so maybe very less is been done. So, with MIGS we target different structures like TM, Schlem's canal in incisional or excisional surgeries, or subconjunctival space like pressure flow or Zen, and suprachoroidal these SIPAs, and canal based like Hydrus or Omni. So, benefits of MIGS are, he says, high safety profile, and it can be combined with FICO or can be done as a standalone procedure also. Usually it doesn't cause hypotony, and future trabeculectomy is not affected as we have it naive conjunctiva. So, there is a long list of complications of all MIGS, and common are hyphaman, IOP spike, then implant related like dislodgement or malpositioning or decimal detachment, retrodialysis, and rarely cyclodialysis also, and peripheral anterior synecdoche formation, which is more with GAD than other MIT, and postoperative inflammation. And rarely you could see retinal detachment or choroidal detachment, CME, IOL dislocation or TCO, or sometime infection also. So, how to avoid or minimize complications? So, one must be very well versed with the technique of gonioscopy and do the procedure only if you are seeing the structure, and don't go blind and just assuming that you are doing the right thing. So complication may still occur, though most of them can be managed. So peroperatively, by giving the incision, there could be hyphema or iris trauma or DMD or cyclodialysis rarely, false passage like we see with GAT or some blood ooze, and postoperatively there could be peripheral anterior synecdoche, corneal edema, rebleed, trabecular meshwork scarring, IOP instability, sometimes vitreous hemorrhage, even malignant glaucoma and persistent inflammation. So MIGS though have high safety profile, but it is a relatively safe procedure compared to other with minimal tissue trauma. But complications do occur and most of them resolve spontaneously or are manageable. Hyphema occurred in as high as 70% of the cases, but most of the time it is mild and transient. And if it is not resolving, then you may have to enter again. And sometimes retained viscoelastic is there or transient rise in intraocular pressure. And other complications like PAS, CME, post-op inflammation, rarely hypotonia or infection. These infections have been seen more commonly with the implant and it is less than the incisional surgery where we don't put any implant. So specifically trabeculotomy, goniotomy or canaloplasty, we see hyphoma more often, mostly transient, and DMD can occur if the viscoelastic is injected into it, or iridodialysis if you are not focused enough, or if there is a bulge of the iris, and cyclodialysis, though rare, can occur, and false passage that is seen more with GAD. And BANG and GAD and KDB, they are almost similar complications. Common ones are hyphema and IOP spike, and vision threatening complications like corneal edema, cyclodialysis or DMD can occur, and rarely vitreous loss or hemorrhage, vitreous hemorrhage can occur, and iridodialysis. So other is GAD, apart from hyphema and IOP spike, then suture related complications at various stages can occur, like initializing the goniotomy or sharp suture tip due to sharp suture tip, or deroofing during deroofing, false passage. Then PAS, they have been seen more with GAD than other MIT surgeries. So eye stent, the specific complications related to eye stent are hyphema and malpositioning or displacement, sometimes blurring of vision or anticipated postoperative other events, then obstruction of the eye stent, IOP spike, endothelial cell loss is seen with most of the stents used, though it is less with eye stent and it was more with CyPass, which has been absolute no. So some other bleb forming mix like Zen and pressure flow, both are similar. One is ab interno and one is ab externo. Only thing is the bleb formed with pressure flow is little posterior than the Zen, and there can be malpositioning or conjunctival perforation or hyphema, device exposure. Then bleb related fibrosis or scarring and capsulation. Bleb infection are rarely end up or suprachoroidal hemorrhage and DMD can also occur. So this hydrous stent can cause transient hyphema, malpositioning or displacement, PAS or obstruction or malfunctioning, IOP spike and even migration. So this is the recent article where the surgical success of standalone MIGS was compared against the MIGS with cataract surgery. So the criteria was IOP of less than 21 or less than 20% from the baseline without increase in glaucoma medications and with without additional lasers or incisional surgeries and without loss of PL vision. And in combined surgery, all of these, but with just a decrease of one glaucoma medications. So what they have proposed that before going for MIGS, you can always try SLT, that will give you a decrease of one or two medications. Other thing is, if you are going for TRAP, it is very important to manage the trap in post-operative period aggressively, because it is the period where the most of the trap failure, and there should be aggressive steroid use and appropriate time of releasing the sutures and going for anti-metabolite injections. So if you manage post-operatively trap well, it is a good surgery and give more magnitude of IOP reduction. So concluding, MIGS have significantly advantaged treatment of glaucoma, offering safe and less invasive procedure. But careful case selection is key to avoid complication, ensure normal BP and discontinue anticoagulants. Though complications are low, but still DMD, PAS, ECL, implant dislodgement, hyphaman, iridolysis can occur. Prevent hypotony at any step during MIGS surgery, and master the art of gonioscopy. If you are well versed with gonioscopy, only then you can go for MIGS surgery. And patient counseling regarding outcome, that is decrease of one medication or limited decrease, that is very important because it's a costly procedure. Thank you.
Thank you, Dr. Srishti. If you'd like to join us, please, on the dais. So we've all had our problems, and I was just noting down what he said. So the iridodialysis, and I was talking to Mohiddin yesterday from Arvind, and it's very heartening to know that most of us are stupid similarly. So the iridodialysis that I have encountered is, like Faisal said, you put in your knife or your instrument and then put your gonio in, so that you know where you're going in the anterior chamber. And when you get confident and stupid, you put your lens first and then you go in. The iridodialysis that I've also had is because the instrument has caught on the iris and I've pulled it while going in. So I'm confessing that I've done that. When Mohiddin said that the only iridodialysis I've had in GAT is when I've gone in without taking care and I've pulled the iris along with it. So that's something which happens. Cyclodialysis, I think, happens when initially you think that you need to give the incision in the posterior DM and it goes a little lesser, and then you do a GAT on it so it widens, and then you have persistent hypotony. So look for a cleft in persistent hypotony following GAT. It doesn't usually happen. There has to be a reason. So a diligent gonioscopy, maybe in hypotony it's not possible, then do a careful ASOCT, and if it persists for more than 6 weeks, it has to be cryoed or it has to be fixed, because that's not going to go away. So before that, those are the 2 points. Thanks. Any points before we go on to the panel about complications?
I think if your AC is deep enough, that's another thing, that you have to deepen the AC.
Yeah.
And inflate it properly, so the angle is exposed nicely, and also there's also a voice, you're dragging the iris along with the. Other thing is, when you're inserting the instrument, you can reduce your magnification, because for goniotomy, one of these angle procedure, you need a high magnification. So if you are operating under high magnification, your field of view is very restricted. So other things you don't see. So when you are manipulating other things, when you want to enter or exit, reduce the magnification, and then go in and then increase the magnification when you have positioned your instrument close to the angle. So that helps you avoid other touching other things.
And of course, the point which Faisal made about, if you're not planning cataract surgery, then be careful with the trypan blue. And that also, I think Venkatesh showed that he did it because it was so nice, and then the patient just said that it was all blurry because the capsule was stained. And now we don't know what to do with the blue capsule. And he confessed that he had to go in and finally take that clear lens out, which he didn't like doing. So we don't know how long that capsule is going to remain stained, and the patients can be very, very upset with that. So that's another point to remember. Don't just use trypan blue if you're not planning to do a cataract surgery in a phakic thing. Right, I think we'll take on the panel. Any other comments? I mean, we learn from each other.
Among all the MIGS, which is the long-lasting, most long-lasting, like it's most effective? What is your experience about it?
Well, I've become a gatter now, so I tend to treat more angle
With
than
GAT.
other with GAT.
Yeah, can we
So I
any
try to-
way prevent the pass that can occur in some cases?
So I'm saying this, and nobody believes me, but everybody uses a lot of pilocarpine post-op. And I've had this conversation that when we used to use a lot of pilocarpine, and then it was just curiosity that let's see what's happened to the angle. And 6 weeks to 3 months down the line, I would always start gonioscoping my initial angle surgeries, and I saw a lot of pass. And a thought occurred to me that we are giving pilocarpine in a raw angle. and
we
the
should
lens
not
iris
give
diaphragm
Pantone.
is going aage.
Yeah.
So I've started giving cyclogel
Okay.
after surgery.
Okay.
For the first
For
week,
first
I give cyclopentolate.
Okay.
I put cyclopentolate at the end of the procedure. I don't want the lens iris diaphragm moving up because you've done a procedure.
Yeah.
It is likely, if there's hypotony, it's likely to be shallowing. If it's shallowing, your raw angle and is going to have an apposition to that iris.
Yeah.
So continuous inflammation if your steroids are also not. So ek to hiking the steroid initially so that inflammation is less, but I have started cyclopleging most of them.
Okay.
I can confess I've told my SRs to do an RCT on cyclogel versus pilocarpine because there's nothing unethical about it. You can do that and let's see what happens.
Okay.
But and now that I do the gonioscopy, it's only an observation, an anecdotal, but you also want to see results which you want to see. So it's just that I've started putting cyclo, so I think there is less pass, but I actually will document it and see.
Okay.
But it's just a small tip that I like the angles, they're quieter, the
behind,
eyes are
post behind,
quieter,
yeah.
inflammation is lesser, and post-operative spikes are lesser now.
Okay.
I don't have that.
Okay. We have been
Pilo also
leaving.
induces inflammation
Yes.
actually itself. so-
Yes, itself.
We have been leaving visco inside the AC.
Yeah.
Like Orogel I am using.
Yeah.
So inside the AC, that has reduced the hyphema significantly.
Yes.
Yeah,
It-
the
except for
hyphema is
the-
much less.
Except for the IOP spikes later.
yeah,
We need to
for
keep
one
that in mind.
third, fourth follow-up,
Yeah.
first follow-up, the
First
IOP
follow-up,
spike
yeah.
is there.
So keep them on Diamox if you do leave
Yeah,
Orogel.
yeah.
But I've learned this AC maintainer business. So
Okay.
the amount of visco that is left is very, because it's a
small amount,
continuous continuous fluid going in. So
Mm-hmm.
I just inject in the angle. It's almost like a donut, which
Okay.
goes
Only
only
in the
at the
angle,
end.
they stay
Only
only
in
in the
that little bit before taking it out and
What do you
hydrating.
inject? Like
Sorry?
which viscoelastic like substance do you use?
Well, I would use hydroxypropyl methyl cellulose. I wouldn't use a 1.4%
Okay.
cohesive because it just
Okay.
doesn't come out after that.
Yeah,
Then the
yeah,
spike.
that's right.
Fezzle is a proponent of air. So everybody says Fezzle sir
Air.
puts air. Yeah, I said my air keeps coming out, but he says nahi his. So when I put in air, I notice that the air is in the middle and the angles bleed sits on the periphery. There is an obstruction and it doesn't come in the center. So but Fezzle is an air person. I am a
I've
a visco person.
Okay. I've also observed like if there is hyphema later on, if it persists, the pus generally develops in the area where the hyphema,
Hyphema
is.
is, yes.
That's true.
Yes, that's true.
Yeah.
Yeah, because it would, I think,
Yeah, pull
it,
the
it would
iris,
pull, no, not just pull, while it's contracting, it might pull the iris, but I'm sure it'll be full of inflammatory cytokines and all that,
Yeah,
which we
inflammatory
hate
mediators, right.
blood in the bleb also,
Yes,
no?
yeah.
So I think for a glaucoma surgeon, we hate blood anyway.
Blood.
So every
Also, the post-op positioning of the patient, that should be in other direction,
From the hyphema. Okay.
from where you have means temporal side.
Ask the patient to lie on the opposite side.
Yeah.
From
ask the
where
patient to lie on the side in which you've operated. So that the bleed is always away.
away from the.
But having said that, I mean, I used to
From
do
his
that.
360 degrees, no?
Yeah. If you're doing a GAT, it doesn't matter.
Yeah,
When you're
but
doing
in other
just a
surgeries,
bang or something.
bang.
But having said that, when you do a bang, and I used to ask them to this thing the other side, that blood used to trickle into the pupillary axis. So they didn't like it either. So I now prefer to just put a head and elevate it so that at least it all settles down.
Yeah,
And
but
it doesn't
mostly
go to
I
the
think the
pupil.
hyphema resolves very fast, no? In
Yes, it
GATs.
does.
Yeah.
Yeah, within 2-3
Yeah,
days it just goes
it's
away.
if you're lucky, 2-3 days. Otherwise, by a week usually we see it's
Yeah, actually
gone.
my question remains like how long has the GAT success remained? Like how many years have you seen that it is
Well,
functioning?
we started doing it only about 1 or 2 years ago.
so 2 years.
So most of them are
well.
reasonably all right. They're off their medications. That important thing about the MIGS surgical outcome is important, that it is without a rise in pressure with a reduction of even 1 drop. So I always think that if I'm 14 millimeters on 4 drugs and post-op 14 millimeters on 1 drug, that's success.
And for long term, we are achieving
Yeah,
it for long term.
it's a success. Then it's not just 20% reduction from baseline. It is also reduction in AGM.
Yeah.
I think we'll see that. Okay, can we have the slides for the panel? Now we have lots of questions, which I've just put in. So this is what I thought, that these are the difficulties that we practically face, and we'll just take them one by one, and any of us can take any of these. So maybe I'll ask Dr. Pandav to take the first one. You are in position, you think, but you just can't see the angle. What do you think would be the problem?
I think you, you have to look at the gonio interface basically. If you haven't put any viscoelastic between the properly, so it has to be nicely covered, and a good blob of visco is actually is very helpful. And then you have to position your microscope and yourself in position, but then you have to position the angle with
Yeah,
the
the eye
gonioscope also,
also.
so that that rotate the eye so that you can see. And the other thing that obstructs sometimes is when you enter the AC, if you're not clear corneal, there may be a little bit of
Bleach.
vessel at the limbus where you have made the incision, and that kind of finds its way into the visco, and that kind of makes it hazy. So in that case, you just remove a gonioscope, wash it off, and then put viscoelastic again. But important thing is not to touch those limbal vessels, otherwise they bleed, and that keeps coming, under your gonioscope lens. So I think those are the usually things that we have.
Especially that limbal vessel thing, and once they keep coming, if your limbal vessel is at that angle, because gravity makes them keep going down, so that really is troublesome. Sometimes you don't know what to do. Faisal, any additions to when you can't see the angle?
And maybe sometimes a tendency to over-rotate the eye also.
Yes.
That's one
I was
possible.
going to say that,
Yeah.
that sometimes you rotate it too much, so then the angle has actually gone beneath the iris, and you keep rotating your microscope, but you just realize that it's the head which is tilted, especially in the ones with the sort of shallow or flatter corneas. If you just tilt it too much, it just hides behind the iris. So that's one thing that I've noticed. Srishti, any
Also,
pointers?
if you are pressing over the cornea too much, that may also distort the angle.
Yeah.
So you have to gently keep it over the
Any
coupling
Desmet
edges.
stria that we see
Yeah.
is a problem. The other thing is we've started doing it in angle closure eyes. So usually that iris is bumpy. So it might be a problem. So sometimes I go in and I put a cohesive viscoelastic to flatten the iris, and that's the problem, that it's a bump. Any other pointers? Puri, you can join in with your Raya Madhuri.
Yeah, yes, ma'am. Ma'am, I have one question for the extreme, the superotemporal and the inferotemporal angles, where the rotation plays quite a bit role in the visibility.
During bang.
During bang, yeah.
Okay.
My question is for bang. So, would a lens with the flange be helpful? Because what I have is a smooth, the normal Swan-Jacob lens, which we have. Because what happens is, at the extreme of the angles, the counter traction is kind of lost while you are
Counter
doing-
traction means?
As in, ma'am, the globe slips off as
Okay.
much as you are doing it in the central part, which is quite clear. At the extreme angle, because maybe of the rotation and the
Yeah.
lens, the visibility kind of hits off a
You
bit.
need to
So-
invest in a very good sister. And you have to insist, where is she today? Because they are the ones, they are better than my residents. Because they are there every time your residents will rotate. So they have to know exactly, if you're really wanting to do that, exactly how to hold the limbus at 180 degrees. I tell them pull it up and rotate.
Okay.
If
And
they're going to pull it down and rotate, that's when
That
it
was
is
it.
going to tilt.
Tilt.
Pull the eye up, and it has to be in that same plane, and they rotate while you're there. If you really want to treat them, that's the main thing. Some people use sutures for traction so that it's easier to rotate, and I don't remember who, but I've also seen them bridle the superior inferior rectus, so they say it's much easier to rotate. So
Lift it
each
in.
to their own.
okay.
I wouldn't go so far, but you have to hold the limbus and rotate it.
Okay. Ma'am, would you recommend it holding it at just one clock hour, or both, like the 12 and 6, and then rotating it simultaneously?
Yes, two.
Both of
Yeah,
them.
both
and then
have to, and then
okay.
rotate it. But it's also easier once you get the hang. If you have wheels under
Okay.
your chair, you just rotate
To-
it and keep going, and then rotate
Okay.
like that and keep going. So you just move. So have the eye in the same position and rotate with that. But now that GAT has come into my
Yeah,
this thing,
that-
I've started doing less and less of partial.
yeah,
But yeah,
partial.
bang with a phaco in a
In a-
controlled patient is what I still do that. But for that, there is also evidence that it doesn't really matter. That's also true. I've heard lots of people say that whether you do about 120 degrees versus 180 degrees doesn't matter. So now maybe you don't need to rotate so much. That had come in from the pediatric goniotomy things where it was recognized. More angle is better. So that's when that rotation had come in. But maybe for adults, when you're doing it, maybe 100, 120 degrees of bang should be all right.
Thank you, ma'am.
I think that you are kind of stripping off 360 degrees, but that also increases the rate of complications. High FEMA is more in GAT and more severe as compared to
Just a bang?
yeah, just
Not
just a bang.
necessarily depends. A bang, I'm okay with
Success is
it.
better with GAT, no? But
Much better
yeah,
with the
IOP
GAT.
is much better.
Much
With the
better.
GAT.
Much better.
Yeah. I mean, there is evidence to say that the more you strip, the better it is. But I think if you look at some of the data, it suggests the minimum you need is about 30 degrees. So whether you want 30 degrees or 360 degrees, I think that's the
No,
question.
sir, I think there's evidence for 360 working more in GAT versus.
Practically, it is.
Yeah,
At least we are
practic-
seeing, more result, better
It
results.
does. At least in
compared
children it works more. In adults, let me look at the evidence again. But there's no question that one goniotomy and two goniotomies would. So in adults also, sir, when it fails, they say do the other angle. So that's where these eye tracks have come in. So must be. Yeah, Purvi, sorry,
No,
one comment. Come to the mic.
360 degree would be like more, give you more effect definitely. But kind of how much would be the difference? Like you have
Yeah.
180 degrees or 360 degrees. Would there be a really significant difference in terms of IOP or, just some difference?
Just one tip regarding this. I've just started recently doing goniotomy, mainly the bang. So what happens sometimes is you are all set, you started doing the goniotomy, but you don't realize and there is pressure at the side port, that entry point where you have
Okay.
just entered. So that gradually leads to leak of that
Yes.
visco.
Yeah.
And then slowly you start losing the sight of the
Yeah.
angle. So that is something we
Yeah.
need to keep in mind, that at that time there should be no pressure over
Especially
the
posterior
point.
pressure.
Yes,
You should
yes.
hold it up
Yeah.
towards the
So I
good
actually
point. Yeah.
use a syringe filled with visco, and on
Yeah.
that I put a
Yeah.
26.
Yeah.
So the moment you feel that the AC is shallowing, you're losing
And then
visibility,
you have air.
you inject.
So then you
No,
have
no,
air.
Fortunately not.
And then when you inject, there's a and then it's all gone. Then you don't see the angle
Those
again.
small
Yeah.
things also we need
Yes,
to keep
yes.
in mind.
Well, little things. Right. Right.
Smudged
Yeah.
gonio lens also. Like sometimes the gonio, we are eating the gonio lens, no? It is smudged because of the
Yes.
previous use and it's not been washed well. That time also the visualization is very poor.
That's why I love
and
the Swan Jacob because it's autoclaved.
Yeah.
So there's no ETO residue, there's
Smudging
nothing
is
on
a
it. So
big thing because we don't identify exactly what is the problem.
Yeah.
Yeah, so many factors involved.
so that one time investment of 50,000 rupees is very good for a long time.
I think San Jacob gives you good visibility.
Yeah.
Only problem is a little heavier. So if you are not very good in your left hand, then you tend to press it a little more.
But the disposable lenses, for stability purpose, they are much better. They give better stability. Only thing is, yeah.
Multiple use, you can't use.
Right. So the minute you make the nick, it bleeds. I'll ask anybody to take this. What do you think? We've, I think, talked about this. The minute you make the nick in your angle, it bleeds. Yeah, we've gone deep. Usually that's the thing, that initially we've gone deep. You just have to nudge it a little bit. Whatever. But otherwise,
Put a little viscoelastic in that area, I think.
yeah, and then carry on.
The high viscosity.
Yeah,
and
go
then
ahead.
that will be contained, and then you can keep working beyond that.
Ma'am, what do we do when we have lot of peripheral anterior synechiae and we are targeting the nasal angle, and we are seeing, especially in the nasal angle, if we are seeing lot of peripheral anterior synechiae, what do we do in that?
So it's very,
Don't do mix.
but it's very easy to do a GSL, a goniosyncylitis, and it's very gentle to pull it down. In fact, the one which I showed you with the air was an angle closure after a goniosyncylitis. So we pulled it, and it's very easy to pull it down, except that when you pull it down, you want it to be clear, and that's when I said, "Acha, inject," and that was that blob of air that you saw. But it's easy, and angle closure glaucoma, once we started doing it, we've realized that they work better. The MIGS the bang works better somehow. And my thought processes, and then when you talk to your friends, I was talking to Monisha Nongipur yesterday, she has a grant on that. She wants to prove that angle closure glaucoma. I said, look at this, I've been saying this, and she's already got a grant from Singapore National Eye Center. So she is looking at the trabecular meshwork and the outflow in PACG and POAG with the same hypothesis that PACG is a trabecular meshwork problem, and it is possible that the outflow is lesser affected than in POAG, and therefore when you treat the TM of PACG, the results of a bang or something, which we have anecdotally seen. You do PACG, you do that, you take it out and you do the phaco along with it. Of course, there's always that, is the phaco working or is it more? But now there is evidence to say that phaco MIGS works better than phaco alone and MIGS standalone alone. So I think if you combine a phaco MIGS, the IOP was albeit about 2.1 or 2.2 mm on evidence, but anyway, the phaco MIGS works better than phaco alone, and it also works better than MIGS alone. So if you combine the two, possibly in PACG, you're getting a mix of both. So if you do a synucleitis, if you see Arvind's presentations, they have only chronic PACG, it seems, because they do just that. They use a cyclodialysis spatula to just pull down the synechiae, open up the trabecular meshwork and do the bang. I use the bang needle itself.
I was going to ask the next question, that which instrument is the best
I
for
use just that. Gently, but of course, just at the iris, pull that down and use the same needle. Then you don't go in and out. Makes the problem, I feel, is just going in and out business. Acha bhala, you can see the angle, then you've gone out, then you've gone in again, and it's all gone. So with that same. So that helps, sir. PACG.
I think there is now evidence to say that even these procedures work in PSCG also. But as you said, it's mostly because they are doing the cataract surgery along with it.
Yeah.
And if you're not doing with cataract surgery, then whether they work or not, I think
I've actually done a
mark.
GAT in a PACG on 5 drugs and Dimox with a clear lens, standalone. And she's off everything except one PGA. So that we have evidence of that. Maybe I should
So what are
publish,
the chances
publish
of
that as a
to
case
see
report
that?
now.
What are the chances of reformation of synechiae?
Yeah, true. So if you do only a goniosynucleitis, they always reform. But I think maybe if you strip off the TM along with it, then possibly
I
that
think even then, because
sticking.
if the lens is in position and if
Yeah.
you have a shallow AC, I think
Yeah.
there would be,
It might.
Synechiae
after a few
formation.
months, we'll know what
Possible,
happens.
yeah.
Yeah.
But you are removing lens along with it, then there's not
then
a
it's,
problem.
it's
then it's,
incomplete.
the problem is lesser. Right, Faisal, anything?
Okay.
Any tips? Okay. Right, this is another problem that we all used to face. AC is continuously shallowing, and I'll please ask all of you to interact and whatever your experiences with. This was initially continuously shallowing AC. Yeah, please. Doctor, please identify yourself. This is Ken Mishra.
Yeah, I am Dr. Pranab Kalita. I am the glaucoma consultant in Chandraprabha Eye Hospital, Jorhat, Assam.
Okay.
Okay. So what I feel is that this AC is continuous shallowing. So initially with the MVR knife, when you approach the angle, I think there is a you pressure on the posterior lip of the
Yes.
I mean to say the 2.2
sclera, yeah.
incisions we make on the cornea, and it shallows. But then what I do, I go in. Then with the Swan Jacob in place, and I see the AC shallowing. Then what you do, my hand is rock steady, so I keep it there with the side. To the left hand, I inject again methyl cellulose.
Okay.
They see it becomes deep. Then I see that now since my MVR is very
Snug.
that little distance away from the angle. With that amount of time I have in hand, I can nicely go and incise it.
Okay. Fair enough.
Other thing is in PACG patients, it's better to give pre-op Dimox or mannitol to cut short the IOP spike during surgery, because in angle closure, it is the IO spikes are more peroperative.
So I think
maybe-
I'm a lazy surgeon, so I don't want to put in another another hole into the eye. But I tend to just take it out and put in visco. But initially, I thought it was very useful, as Purvi said, to have the needle on a visco syringe. So you don't have to go in and out, and you don't have to put in a second. So you do the bang or the goniotomy with a 25 gauge needle, rather than doing it with an MVR blade.
Okay.
So if you go in with on a needle on a syringe, and it starts shallowing, you just ask your assistant to push in a little bit of visco from
And there,
behind.
no, the problem, yes, madam,
Yeah.
of course, but the problem is that in MVR knife, the length of the needle is too good to approach. But in that 26
No,
needle,
25
1 ml
gauge,
series,
25 gauge, 1.5 inch.
1.5 inch.
1.5 inch, 25 gauge.
Okay.
The
That is-
normal, with your
Okay,
2
okay,
cc
okay, okay,
syringe
okay.
जो
One,
needle आता है,
one,
same,
oh, one,
that
okay,
same
okay,
thing.
okay, okay, okay.
So 1.5 inch, 25. Of course, you have to reach the chota half inch 26 gauge. You can't reach
Yeah,
that.
yeah.
You can't do
Okay,
that.
okay,
That's
okay,
true.
And also you can make the incision smaller, not bigger, and use a high viscosity viscoelastic. I mean, Helon GB or NeoVisc, 1.8. I think then that shallowing doesn't happen.
Yeah, but the commonest problem is, of course, initially you tend to press down because you're only concentrating on that. And you also tend to press down with your lens. So that also will push it out in anything. Sometimes you do that or you press down. But yes, high viscosity, viscoelastic in the angle is the key. But of course, to coat the surface before that with, because initially the other thing that we tend to do, I've done that, scratch the cornea while going in. You're not sure. You're so this thing about looking at the angle that while going in, you don't realize that the cornea has also been scraped. So I always use HPMC first, soft shell, and then go in with cohesive viscoelastic in the angle. Faisal, would you do that while using visco?
No, I usually only the cohesive
Only
viscoelastic, and I think main reason is you are unknowingly pressing the
Posterior limb.
posterior. That is the most problem. You just
Plus pressure of the gonioscope.
yeah.
Yes, and the pressure on the gonioscope. Yeah. And of course, that makes the iris bulge up again, and then again your angle visualization is gone, and then you'll say, "Chodo yaar, just do the fico and let's come out." But wo chodo yaar nahi karna. Just go it. It'll roger your OT list because you won't realize that you spent 15-20 minutes in only seeing the angle. Surgery to abhi shuru nahi hui abhi, and then you think that you have, but then just hang on to it. Have a small OT list when you're starting with MIGS surgery, and then when you see the results later, you'll really whatever. So the next I've seen is sometimes the trabecular meshwork pass is very scratchy. It's not smooth. Sir, have you encountered that? That somehow there's something wrong and you think there's...
About in?
The trabecular meshwork pass is not very smooth. It's a little... It's not like you'd want it.
No,
Any
I think-
phenotypes
I
that you've
think if-
noticed?
I think you have the right place, then
Usually it does.
Usually doesn't happen. I think.
Faisal, you've noticed anything, especially with the GAT, it's just not smooth enough. The pass is...
Maybe the right.
I think juvenile open angle
Glaucomas
glaucoma
are-
sometimes you have that
that.
issues because there the Schlem's canal may not be completely developed in some cases. Uh, if the Schlem's canal is properly developed, then you don't have a problem. But some of these juvenile angle open angle glaucoma, I think they have an issue with the Schlem's canal, and there the success rate of cannulating 360 degrees may not
Is
always
lesser.
be successful. So there you can encounter a resistance.
Srishti, any phenotypes that you've noticed is not easy to...
Yeah, sometime while pushing the suture, there is obstruction and you are not clear whether you are going in the canal or there is a false passage formation. So in that condition, what to do?
Yeah, so then I just garrote it out. It never comes out of the canal, believe me. When you start just pulling it out from the other side, it's never that it'll come out of the canal. Somehow it always does garrote, how much ever it is, and you realize, "Arey, yahan tak it's almost till here," so you're almost done 220 or 200 degrees or whatever. So the phenotypes that I found this TM to be a little gritty is if you do it post aphakic. Somehow something happens to those eyes. The corneas are so thick, and I haven't found the reason. I've asked every cornea specialist I catch hold of, why is the cornea so thick in an aphakic and it's rigid? The IOP also when you take, be sure to take corneal thickness, and also in children, because aphakics, the cornea becomes very thick and rigid, and maybe something happens to the sclera also. Removal of the lens might, I don't know why that happens. And Axenfeld is another juvenile, or like sir said, a developmental condition where something is wrong with that meshwork. Structurally, it's not as we this thing. So those are the few phenotypes where you feel it is not. I think it's fair not to force your way through.
Yeah.
If it's not smooth and it's not coming and you're not feeling it, it's better to say, okay, we'll call it a day today, and maybe he'll require a trab later, and tell the patient that. It's okay to eat humble pie once in a while and say, listen, we tried to do this, but we couldn't. It's okay, we couldn't. So we say that all the time. There's no
So if there is-
yeah,
If
yeah,
there is
Pooja.
some resistance and then you force it,
Yeah,
that means it has
it's
gone
worse.
somewhere.
Yeah.
I think last time we had it was the suture actually came to the anterior chamber. It crept on the angle over the trabecular meshwork.
Okay.
And I could see it coming,
Yeah.
I was very happy, okay, I've got it. And when I
Pulled it out.
started pulling, I thought, oh, it's in the anterior chamber
Yeah.
only. So it has come only halfway through and half was in the anterior chamber.
Yeah, once I
Yeah,
had
yeah, you were
an
saying
encounter where the tip was not properly made. It was not the
Yeah,
perfect umbrella.
okay.
It was half made.
Okay,
It was
yeah.
triangular shaped, and
Okay.
that's the time when it caused real problem. Like,
Okay.
yeah,
Yeah, it
lot of
might also
difficulty in
go.
passing
It
through.
might also go
Yeah,
right
it
through.
went to the trabecular meshwork, like said, and it came in
Yeah.
the AC from the other side.
It
Yeah.
can come to, if it is sharp actually.
Yeah.
So it has to be
So,
rounded.
Yeah, it was
Has
not
to be
rounded well.
And the other problem I've noticed is in the bang, initially, sometimes we didn't bend it enough. So if it's not exactly 90 degrees, it's just one pokey thing. Then, you need it 90 so that it sits on the schlems and comes out. And sometimes it is too much. So if it's rounded and then you want to, manipulate that. So I think, Murli, you're here. Your comments on, we're just looking at problems. Any phenotypes or you've noticed when the trabecular meshwork pass is not smooth enough while doing a GAT or any procedure? What is your experience? Please identify yourself. I know who you are, but introduce you to everybody else.
Thank you, ma'am. I'm Murlidhar from I Foundation, Coimbatore. So, madam, in some patients, as you already mentioned, the developmental anomalies, Axenfeld Rieger's, the pass is not smooth. The other, this thing is in uveitic and in angle closure glaucomas also, sometimes the suture tends to come out at the site of a peripheral anterior synechiae.
Okay.
So,
All right.
it tends to come out at the site.
So when you're doing an angle closure, I asked Mohidin the same because he seems to show a lot of angle closure. So you've done a goniosynculitis, you've done a good goniotomy and it's come through.
Okay.
What I get scared of is, what about the PAS underneath where I haven't touched it? When you pass that suture through, is there a possibility of there being an iridodialysis or pulling out the synechiae? No,
It has
it doesn't
never
happen.
happened, madam.
The synechiae just get
The synechiae
cut.
just broken at
They
that,
just break
yeah.
and then they come. Okay.
But the problem is sometimes they reform again. So
Okay.
post-operatively, even if we give them intense steroids and pilocarpine, they reform again.
So we just talked about pilocarpine, Murli.
That's
So my thought process now is pilocarpine is the problem for PAS. Because it's also pushing the lens iris diaphragm forward.
Forward, yeah.
So if what are your thoughts on possibly giving cycloplegic in the first week with the intensive steroid to push it back down?
If the anterior chamber is shallow and I had a couple of patients in which the anterior chamber was shallow or the suture had tracked into the supraciliary space.
Okay.
So in those patients, I do not give pilocarpine. Whenever there is extensive manipulation, like I have to do forward cannulation and then I have to do reverse cannulation to get it out. Or if there is an intense inflammation in the postoperative period or extensive bleeding, in those patients I avoid pilocarpine. I give intense steroids and I give cycloplegics for a period of time. But in the rest,
So it's very interesting that in Bascom Palmer, Peter Chang, he gives pilocarpine if there is extensive hyphema because he says that I want the surface of the iris to be as much as possible for the hyphema to drain. I mean, each to his own. I said I would never give pilocarpine if there is extensive hyphema. I would want it to go back. But he says if you give cycloplegic, then the iris also, I mean, there's dilatation also secondarily. And then there is no iris surface for the hyphema to absorb because it's going to absorb through the iris.
But if your
I said,
angle is
"Wow,
open,
very good."
Sir,
if your angle is open, the Schlems canal is open, the hyphae will go through that anyway.
yeah, I did one
So
case.
you don't need iris there to absorb the blood.
Just an interesting case. I did a phaco-bang in a patient. Post-operatively, he has a hyphema, and there was a blood in the retroanticular place in the back. That doesn't resolve even after 3-4 weeks, and we have to go again and do IA to remove that. Because the patient was constantly complaining of blurring vision, I just waited that it may resolve, but that didn't. So it hemolyzed, but that remained there behind the lens.
Was it behind the lens?
Yeah.
Right,
Yeah, once
Within the back, like
Sometimes
CBDT.
I know I heard someone saying that it went into the Burgess space.
Burgess
actually,
space, yeah, if it
behind,
goes there.
behind the capsule. And then what do you do about that?
They have to do an anterior vitrectomy, I suppose. Sometimes with the pseudofakes, it just tracks through the zonules and it goes.
Actually, did in a couple of cases where there was a PCR Where there was a PCR and in a few patients who had a dialysis also, limited dialysis. In those patients, it went into the vitreous. We gave vitamin C and, of course, involved the vitreoretina consultant also. It resolved almost inevitably.
From the vitreous hemorrhage
No, I
also.
think
But
it goes
if
in the
they're in
vitreous,
the-
that will get
That
absorbed,
is
like
that.
any
But-
vitreous hemorrhage, because
Yeah,
but
vitreous
if-
hemorrhage gets absorbed.
The Burgess space
eventually.
maybe.
But if it
because
is
because
trapped
there's
in
a-
the capsular bag,
In the
beyond
bag, it never
IOP,
goes.
it will
In
not
the
go.
bag, it never goes. Yeah.
And it's a very difficult time for you post-operatively if it's there's vitreous hemorrhage. Somebody who was 6'18" is now hand motions. So then it's really troublesome to wait. So I'm very wary of doing it now in pseudofix.
And this patient
AFix
was
also.
one night.
Yeah, my God. And AFix also, that's also a problem. Even in AFix, it tends to just trickle back and then so then it's a problem.
This is the one issue, the hemorrhage. This is the one issue actually. That this hemorrhage, this is bleeding, which is preventing us from like going ahead
Yeah.
more and more with
Yes.
MIGS.
Yes. And of course, blood thinners. That's something I've learned the hard way. Whether or not what the evidence is, I don't know, but I have noticed if I stop the blood thinners 5 days prior, I'm safer than invariably it's a post hoc thing. You tell them, you're fine, yeah, I'm fine, and this, that. It's not enough. The history has to include, are you on aspirin? Especially hypertensives. Are you on aspirin is a direct question. Not that, yeah, I'm all right, because they think they're not on antihypertensives, but some medicine guys give them aspirin, low dose, that you be on aspirin, your BP is fine, everything is fine. So those I'm very careful of. And then the resistant bleeds, then I realized, yeah, I'm having aspirin. And I said, oh God, this is what happened. So be careful about blood thinners before.
But
prior to-
patient, mild glaucoma patient on one drug, it's better to try SLT before going for MIGS or like that.
So what is your experience? Is it true that somebody who does well on SLT is a likely candidate to do well with MIGS? I mean, that's a debate going on. There is some evidence to show that those who, once you do the SLT, then your MIGS is not likely to do so well because the trabecular meshwork itself, you've changed the character of it. So the only MIGS that will work is if you remove that trabecular meshwork. Whereas if you put in a device or an eye stent, it may not. But then some say that an SLT working means the outflow is good. And therefore, the MIGS is likely to do well. So any thoughts on what we should do?
I don't think there's any evidence
Correlation,
either
okay.
way there. It's just
But
anecdotal.
logically, the
But-
SLT doesn't cause scarring, so it
Yeah.
may not happen.
Yeah, so it should not make a
It
difference.
should not make a difference. And that
But,
thought
I
is,
think if your MIG is not working or SLT is not working, then the problem may be beyond the trabecular meshwork, is into the drainage channels or somewhere else. Because TM is not the only place where you have resistance.
yeah, so that thought is all right, that if the SLT is not working, then maybe you're mixed. In that sense, you're doing an SLT first, may be some indicator for not or doing MIGS. So if the SLT hasn't worked at all, then maybe you tell them that it's less likely. I don't know. But that's another thought. How many of us would do SLT as first line for POAG? You do SLT in all your POAGs? Okay. Okay.
Yeah, in selective cases like patient who doesn't want surgery or allergic to drugs or in pregnancy, you want to do some extra.
I think
I think SLT
think
is,
we are not
yeah.
doing SLT as much.
As we
There's
should.
probably potential for doing more.
Yeah.
I think we are underutilizing
We're,
this.
yeah, because that's the general thing that otherwise SLT
Because
is
it's very easy to prescribe a drop,
Yeah.
You just give, drop and you put it. And SLT you have to
Yeah.
you do
go
a
to the
procedure.
machine.
Yeah, so you have to do a procedure.
Yes.
Here you are not doing a procedure.
Also the machine, the quality, because the previous one we had, that was very good, but this one is little, you have to bend forward and it, because of its design, it's
Yeah, so
difficult
the-
to do it. Yeah.
I mean, preferred practice guidelines are POAG, first line of treatment SLT. Everybody says that. De novo eyes, if you get. It is a good idea. I think the SLT madam has come. Ma'am, aajao. Discussion on SLT versus, do you do SLT in all your POAGs? Dr. Mayuri, of course, Dr. Mayuri will introduce herself, but she's one of the few SLT madams.
Actually, I started SLT in 2011
I know.
when everyone was opposing me when I started. That
Yeah.
it is
No,
going
I
to
was
be a
supporting you.
failure.
I was supporting you.
Thank you, sir, for that. And we also publish our data. 3 years follow-up. we found out that if you do it in juvenile open-angle glaucoma, it's not going to work. Then if it is a virgin eye, ocular hypertension, 1 or 2 drugs, those patients, they do well.
And high IOP?
Yes, of course. Higher the IOP, more is
Better,
the fall.
yeah.
Okay, thank you, Sushma.
And ma'am, since
I
this
remember one patient of a juvenile open-angle glaucoma where it worked for some time at least. The reason was that the young patient, he had to go for the exams, and his pressure was really fluctuating a lot. And he didn't want to surgery because he has exams. So I said, okay, I'll try SLT for you. May work, may not work. It worked for 3-4 months. His exams are over, and then we did the surgery.
Yes, that is also one of the indications, sir.
pregnancy
But
is one indication.
when we do the SLT, and particularly in the private practice, the price is, so many people, they do calculate. If you are doing it only for one drug, suppose patient is on PG, it is not worth in that case, because after 6 months, again, they are going to back on that.
Okay, so in your experience, how long does it last?
Yeah. But
No, how long does it last, ma'am? One SLT, in your experience, how long will it last? It does.
more, about 60% of the patient, it lasted more than 2 years.
Okay.
Because we were very selective in our.
Alright, okay.
Initially, we started with all, and then we realized that it's not going to work. And one patient, we end up in surgery.
Okay.
That lady was a young lady and already was on 4 drugs.
Okay.
So because of, and some patient where there is ocular toxicity because side effects of the medicine, there it is good idea to do SLT in those cases.
So one discussion was, ma'am, and what are your thoughts on that, that an SLT working, is that going to be a good indicator to do a MIGS later?
Maybe, yes.
Okay, because the outflow you think would be
Yes.
working.
But see, SLT, the mechanism is different. You are just cleaning up the meshwork, making them as good as the new one. So
But
that's
yeah,
the
I think
advantage.
what Sushmita is saying that, because if you, make the TM more permeable and IOP is low, that means the rest of the system is working.
working.
Yes,
Makes
it
So
is
at least
good.
there's
So
no
maybe-
problem with the, Schlems
No.
With the
canal or the
Schlems and
drainage
the
channels.
outflow.
Yes.
And there, if you are doing MIG procedure, it's more likely to work. Maybe.
Sir, to be very frank, my practice is a referred practice. I do more of a TRAB rather than MIGS because all those patients are advanced cases of glaucoma. But in such cases, any MIGS should work. Eye stent or the GAT or the bang, I think it should work.
And the other problem with us not doing the SLT is again referred practice, cocktail
Yeah,
of drugs,
exactly.
advanced glaucomas. So, that's true. But like sir says, we are also lazy and we don't do SLT in our ocular hypertensions and the ones we also get to be lazy.
And one patient, today we have 6 years follow-up of that gentleman, 74-year-old. The daughter is ophthalmologist in USA.
Okay.
She came to India for the father. He was on maximum tolerated treatment, but not on the target, and never wanted to go for surgery.
Okay.
So in that case, we did SLT. He's doing fine even today.
Okay, nice.
So we have 5-year data on SLT in angle closure. I think the success rate, Fazil, who was that?
Yeah, it's good actually. It's more than 70% is
60%, 70, up to 5 years. SLT in angle closure glaucoma.
So again the thought that angle closure is a TM problem and the outflow is good. so that's what MIGS is telling us. Possibly the hypothesis is that. Last question, we have 5 minutes more and I'll take sir to do that because he's the only one amongst us who has patience rich enough for the eye stent. So when the eye stent goes astray, what do we do?
I think sometimes it gets dislodged when you're doing it, and because your AC is filled with viscoelastic, usually high viscosity viscoelastic, so it doesn't kind of float away anywhere. It stays somewhere in the vicinity. So you can reload it in the AC also, or you can just grab with the nice force and bring it out and then reload
So
it.
does this happen with the inject and the W as well, where the flange is bigger? Now
it
does.
It is related to basically how it is embedded.
Okay.
Into the was embedded in the right place into the typical meshwork or not.
Okay.
And usually it happens when you are not looking at the angle and fast. So because you're looking at a slight angle, and when you inject it is not going straight, it's not going perpendicular, it's going a little angle.
Okay.
And then it's going to get dislodged.
But it's possible to
reload it in the AC itself. But if you remove your viscoelastic and then if it gets dislodged during your cataract surgery, then probably you'll have problem. But it sort of never happens.
Anybody has an experience of eye stents going astray or not going astray? Murli, any experience with the eye stent? It won't get recorded otherwise.
Once it got implanted in the trabecular, in the scleral spire actually. So
Oh.
I picked it out with the microforceps, got it out and reloaded it and then
Reloaded
pushed.
outside.
Yeah,
So
reloaded.
it's possible to do both.
Yeah,
You
it's
reload
possible
it
to do.
outside as well as.
It's
Did you ever
possible,
try reloading within the SA?
No, madam,
you
I
haven't tried.
haven't. So it is possible.
I did try once, but sort of then you are manipulating in the anterior chamber and you don't want to do that.
Okay.
So my first attempt failed, so I just took it out and then reloaded
with the-
outside and then went inside.
With the same microforceps, the vitrectomy microforceps?
4 clicks you have you have 4 clicks with the current iStent W injector.
Okay.
So
4 by 3 injects, no?
two
Oh, you have 4.
clicks you deploy 2, madam,
Okay.
and one actually went into the trabecular mesh.
Okay.
So when you have a mal deployment of one, what you do is you go to another site and deploy the second.
Okay.
And then you pull out this with a microforceps, reload it, and then go back and you shouldn't try to pull it out before you have deployed the second.
Then second one. Okay. Fair enough.
Yeah, that's the recommendation. Yeah.
Okay. Then deploy it out. Well, we are short of time, and we thank you very much for a lovely discussion. We had lots of fun, the few of us who were there, and thank you for a happy MIGS, everybody. Yeah. Sorry. Group photo, please. Sorry, I always forget that.